Welcome, Dr. Deepthi. Thank you for joining us again for this neurology series lecture. So, Dr. Deepthi has come again to us to discuss regarding immune-mediated neuropathies. Over to you, Dr. Deepthi.
Good afternoon to all. Continuing with the series of neurology lectures, today we'll be discussing on immune-mediated neuropathies. This will be the basic outline of my talk. Even before dealing with the immune-mediated neuropathies, we need to see how to recognize various kinds of neuropathies or different patterns of neuropathies, and the most important immune-mediated neuropathies, which include Guillain-Barré syndrome, CIDP, multifocal motor neuropathy, various neuropathies which are associated with systemic disorders involving the other systems and including the PNS system, and neuropathies associated with other autoimmune disorders and vasculitis. So the peripheral nerves not only include all the spinal nerve roots from the cervical, thoracic, lumbosacral regions, but also it includes from cranial nerves, not including the second cranial nerve, all the spinal nerve roots, dorsal root ganglia, peripheral nerve trunks and the terminal branches, and the peripheral autonomic system. So we'll be discussing about the immune-mediated disorders of involving this part of the neuroaxis in the peripheral nervous system. So, in peripheral nerves, the various nerve fibers are of various types A, B, and C. A is further divided into alpha, beta, gamma, and delta, and each type of nerve fiber subserves different functions. It gives motor functions, such as A alpha fibers is predominantly involved in motor functions, A beta fibers for touch and proprioception, A gamma for muscle tone, A delta for pain and temperature, B and C for autonomic, and C is also for temperature and touch as well. So when we are dealing with a patient with a predominantly a neuropathic disorder or peripheral neuropathy, we need to ask these 7 key questions. We need to know what are the systems involved, either motor, sensory, or both, and autonomic, or they occur in combinations of motor, sensory, and autonomic. Then second question we need to see or elicit during the history and the examination is what is the distribution of the weakness, whether the weakness is distal versus proximal and distal, whether it is symmetrical or asymmetrical, or is it focal versus asymmetry versus symmetrical, and what is the nature of the sensory involvement. Is it large fiber involvement, which involves the impairment of the vibration, sensation, and proprioceptive loss, or it is a small fiber involvement which looks at the temperature loss or burning dysesthesias, or it could be a combination of both small fiber and large fiber neuropathy. The next question we need to ask, is there an UMN involvement along with an LMN involvement? And at that point, whether it is with sensory loss or without sensory loss. The fifth question we need to ask carefully during the history and examination is what is the temporal evolution of the symptoms, because this is the single most important question which helps us to figure out what could be the underlying etiology for this kind of a neuropathy presentation. So acute presentation is any time between days to 4 weeks, classical disorder like we know as GPS, subacute being 4 to 8 weeks, and chronic if it is more than 8 weeks, classical disorder being the chronic inflammatory demyelinating polyradicular neuropathy, otherwise known as CIDP. We also need to know whether the neuropathic disorder which we are dealing with is a monophasic, progressive, or relapsing and remitting. And often this information is elicitable at the history level itself. The next question we need to ask, is there an evidence for an hereditary neuropathy? So to carefully take an history of a family history of neuropathy, examine the relatives foot and hand to look for any signs of neuropathy. And if there is a lack of sensory symptoms despite sensory signs with distal muscle weakness, most often they are HMSNs, or the hereditary sensory motor neuropathy. The last question is again to look at the etiology for the neuropathy presentation. What are the associated medical conditions, like such as cancer, diabetes, connective tissue disorders, autoimmune disorders? We need to take a detailed medication, drug, toxin history, or is there, and what were the preceding events, or was there any intake of drugs and toxins prior to the onset of the neuropathy symptoms? So these 7 questions will help us to discern what is the pattern of the neuropathy which we are dealing, and help us to figure out the etiology, and hence we can go in an appropriate treatment direction. So based on these questions on history and examination, there are 10 patterns of neuropathic disorders which has been described. Pattern 1 being symmetrical proximal and distal weakness with sensory loss, and the classical disorders being the inflammatory demyelinating polyneuropathy or polyradiculoneuropathy, which is the GBS and CIDP. The second pattern is symmetric distal sensory loss with or without distal weakness. This is our classical length dependent neuropathy, and the most common being idiopathic sensory polyneuropathy and diabetes. And all the metabolic disorders including drugs and toxin, they cause length dependent neuropathy and often present as symmetrical distal sensory loss, most and often with distal weakness. The third pattern of neuropathic disorders, they can present with asymmetric distal weakness with sensory loss. Now this can occur with the involvement of multiple nerves, the classical being which is called as the mononeuritis multiplex, classically seen in vasculitis and leprosy, hepatitis B, tumor infiltration such as lymphomatous infiltration. And this asymmetric distal weakness with sensory loss can also occur with involvement of single nerve or single nerve regions. So this can present either as a mononeuropathy, such as carpal tunnel syndrome. They can present as plexopathy, like Parsonage-Turner syndrome, or idiopathic brachial plexitis, or radiculopathy. The fourth pattern is asymmetrical proximal and distal weakness with sensory loss. They are classical presentation of plexopathy and or polyradiculopathy, and usually the infiltrative disorders cause this form of a neuropathic presentation. The infiltration can be because of the meningeal carcinomatosis, lymphomatosis, sarcoid, amyloid, or idiopathic. Pattern 5 is asymmetrical distal weakness with sensory loss. Now, this has to be seen with or without the involvement of the UMN signs. So, if there are definite signs of UMN involvement, then diagnosis more often than not the anterior horn cell disorder, such as motor neuron disease or ALS. If it is without upper motor neuron findings, other anterior horn cell, other motor neuron disorders such as progressive muscular atrophy, juvenile monomelic atrophy, or Hirayama's disease, multifocal motor neuropathy, which is often a mimic of LMN variant of ALS. In certain cases, we see. The sixth pattern is symmetric sensory loss with distal areflexia with upper motor neuron findings. Now, this is myeloneuropathy, classically seen in vitamin B12 deficiency or the subacute combined degeneration. Other disorders, other deficiencies like vitamin E, copper deficiency, leukodystrophy, hereditary spastic paraparesis plus syndromes and all, they can present, both have cord involvement as well as peripheral nerve involvement. The seventh pattern is symmetric weakness without sensory loss. Then this can occur with both proximal and distal weakness, or with distal weakness. With proximal and distal weakness, pure motor syndrome, we can consider spinal muscular atrophy. And with distal weakness, hereditary motor neuropathy or atypical Charcot-Marie tooth disease. The eighth pattern, focal midline proximal symmetric weakness, can have selective neck extensor weakness or bulbar weakness and diaphragmatic weakness. All these can help in further differentiating the underlying disorder. Ninth and the 10th pattern, asymmetric proprioceptive sensory loss without weakness, that is specifically for neuronopathy or dorsal ganglionopathy. The classical disorder described is the Sjogren's syndrome, where they present with severe sensory ataxia because of the large fiber and dorsal root ganglion involvement. And the 10th pattern is the autonomic signs, symptoms, and signs. That is a pure autonomic neuropathy, which can be seen in HSAN, amyloidosis, or the pan dysautonomia, which could be a variant of a GBS. There's the same 10 patterns can be easily put into a 3 by 3 table, and with a symmetric and asymmetric presentation with proximal, distal, with sensory and motor involvement, and can be worked out in this. This will be an easy slide to remember once, to figure out what is the pattern of neuropathic disorders and their various etiology. Now, immune mediated neuropathies can present as a mononeuropathy, plexopathy, radiculopathy, mononeuritis multiplex. They can present as a symmetrical or asymmetrical polyneuropathy. That means multiple nerves involvement, or they can present as a polyradiculo neuropathy. Now, before going into the various disorders, the conduction of the nerve impulses from the cell body to the throughout the axon to the nerve muscle junction goes via two process. One is a continuous conduction, and other one is a saltatory conduction. So all the myelinated axons will have saltatory conductions. That is, the nerve impulses will jump from one node of Ranvier to the other node of Ranvier, and this is a faster way of conduction of the impulses. But in non-myelinated axons, or if the myelin sheath is destroyed, the axons will continue conducting. So that is a continuous conduction. It is not like that they will not conduct any impulses from the cell body to the terminal part of an axon. So, when we look at neuropathy disorders, pathology wise, the process can be an axonal process or a demyelination process. So, it can either be an axonopathy or a myelinopathy. So, myelinopathy, the hallmark disorder being at our level is a Guillain-Barré syndrome or a CIDP. Axonopathy, the hallmark disorder, we can take it as a diabetic neuropathy, diabetic distal sensory motor polyneuropathy. So here myelinopathy, because the myelin sheath is gone, so the conduction of impulses is really slowed down. So they have a more of a rapid onset, and whereas axonopathy is usually a length-dependent neuropathy and is more of an insidious onset. And once the myelin is regenerated, they will have a rapid recovery. Whereas when the axon is affected, it is when axon is affected, it causes a slow recovery. Usually, axonopathy is symmetrical because the drugs and the toxins and the metabolic affect the cell body, and hence the terminal part of the axon gets affected. Thus, the longer nerves are affected first compared to the shorter nerves, and this forms the basis for the length-dependent neuropathy. And axonopathy, that's why, because of the length-dependent neuropathy, has more of a distal weakness, whereas in myelonopathy, it is a non-length dependent neuropathy, and it can cause both proximal and distal weakness, and it is not length dependent. Doesn't mean that it will start off from distal weakness and then go to proximal. Both proximal and distal can happen at the same time, and also cranial nerve involvement can occur at the same time when there is a limb involvement. So if a patient presents with a bifacial weakness or a low motor type of facial weakness on one side with a characteristic ascending paralysis, then it is a classical non-length dependent, and we can think that it is a GBS presentation, AIDP presentation of a GBS syndrome. Myelinopathy has a global loss of reflexes because the nerve fibers which conduct the impulses for the reflexes are the large fibers, and they have the maximum amount of myelin because of the faster conduction of the impulses. Now, once the myelin is destroyed, so the reflexes will also get lost if the large, faster conducting myelin axons are affected, of which the myelin sheath is affected. Myelinopathy, motor more than sensory. Axonopathy is the classical glove and stocking pattern of distribution, and myelinopathy is mostly seen with the raised CSF protein, whereas in axonopathy, CSF protein can be normal. The same thing can be reflected in a nerve conduction study. Nerve conduction study, or NCV or EMG, is just an extension of our clinical examination. It is not always a diagnostic test, and in a setting of in a proper clinical setting, it has to be interpreted. So when we come to neuropathy, it can be an axonal type of neuropathy or a demyelinating type of neuropathy. So in nerve conduction studies, we stimulate a nerve and we record the impulses from the distal to the stimulation. So hence we get a action potential. So there is a different action potential for the motor nerves, and there is a different action potential for the sensory nerve. The summated potential of all the motor action potential is called as the compound motor action potential, or the CMAPs, and the summated of all the sensory nerve action potentials are called as the sensory nerve action potential, or the SNAPs. So in case of when there is a nerve action potential, it takes a certain time to evoke a action potential, and the amplitude of the action potential depends on the axon, and how fast this impulse is achieved, that is the distal latency, and the conduction velocity depends on the myelin. So in axonal degeneration, the amplitude is reduced because of the axonal loss, hence the CMAP amplitude will be less, whereas it can be normal in the demyelination. The distal latency depends on the myelination. So if the myelin is destroyed, the distal latency will get prolonged in the demyelination demyelinating type of neuropathy, whereas in axonal type, it may be normal. Conduction velocity again will be slow because of the impairment of the myelin in the demyelinating type of neuropathy. Conduction block, temporal dispersion, all this can be seen. It's not important at your level, but can be seen in these other things we look for when we're dealing with the demyelinating type of neuropathy. Similarly, in SNAPs, the distal latency and the conduction velocity will be slow in the demyelinating type of neuropathies, and whereas it can be normal in the axonal type of neuropathy. So just to briefly give you an example, this was a 26-year-old gentleman who presented with 1 week history of weakness of both upper limbs and lower limbs, with an antecedent illness of an upper respiratory tract illness with 2 weeks prior to presentation. So our clinical diagnosis was, clinical localization was to, and on clinical examination, there was both proximal and distal limb involvement with with areflexia. Hence, the clinical localization was to roots and nerves, and the etiology, because it was within 1 week of less than 4 weeks of presentation, we had considered Guillain-Barré syndrome in this gentleman. The nerve conduction study, here we can see a significant reduction in the amplitude. So these are the CMAPs and these are the SNAPs. So the cutoff in our lab is 10. Anything more than 10 or more than that is normal CMAPs. Here we can see the CMAPs are 2.7, 3.4 in the median, ulnar nerve 0.5, lower limb further decreased, and here the SNAPs are normal. Here the SNAPs, the amplitude we take it as 20. So everything is more than 20, and hence the SNAPs are normal. Now the other thing to look at is the distal latency. The cutoff in our lab is 4 in both upper limbs and lower limbs at your level. So here the distal latency is 3, 3.4, 3.1. These are not prolonged, and the conduction velocity, the normatives which we take in our lab in upper limb is 50 to 60. So anything more than that is normal, and in lower limb we take at least 40 and above. So anything above 40 is normal conduction velocity. So here we can see the conduction velocities are also normal. So here we see only there is axonopathy, only the CMAPs are reduced. So in this clinical setting, this is an acute motor axonal neuropathy, which is an Aman variant of the GBS. Now, this is a 55-year-old gentleman, again, who came with 3 days history of both upper limb and lower limb weakness, and clinical examination showed both proximal and distal muscle weakness, areflexia, and he had bifacial low motor neuron type of facial weakness also. Now, we will look at his conductions. So here we see the amplitudes are also reduced. The Cmaps are less than 10 in most of the nerves. At the same time, we need to note that the distal latencies are more than 4. Here in median is 6. Here in peroneal nerve is 7.5. Other side peroneal is 6.7. In tibial is 13.2. Although we can consider median as an entrapment site, so it can have distal latency if he has a carpal tunnel syndrome. But then the non entrapment sites such as tibial site, phrenic conductions, we take it as 7 to 8. It is 11.8 here. So there is evidence of unequivocal prolongation of the distal latency. So that is one evidence of the demyelination. Now coming to the conduction velocity, like I mentioned, the upper limb we take it as 50 to 60. Now this is significantly lower than 50, and in lower limb we take it as 40, and here we can see it is 30 to 26. So there is slowing of the conduction velocity, and the snaps are not even responding to a stimulus. And there is blink. There's the blink reflex, which looks at the trigeminal and the facial nerve function is also affected. So this in the correct clinical setting was acute inflammatory demyelinating polyradicular neuropathy. That is another GBS variant. So with this background knowledge on neuropathies, we'll talk about the immune-mediated neuropathies. Now, the immune-mediated neuropathies are broadly classified into acute versus chronic, because they have management importance, because management differs in both group of disorders. So acute immune-mediated polyneuropathies, they are classified under the eponym of GBS, which is a heterogeneous condition and has several variant forms. So here I want to drive an important point that AIDP is not equal to GBS. GBS is a syndrome under which there are several types of variants, of which AIDP is a variant, AMAN is a variant. So AIDP is not same as GBS. So AIDP comes under GBS. And for chronic immune mediated neuropathies, the phenotypes of chronic immune mediated neuropathies are typically described in terms of their similarities or difference to CIDP. So CIDP can be typical or variant form or atypical form. So if we have a neuropathy which is gone on for more than 8 weeks, we will try to classify whether it is more typical towards a CIDP or not, or like a variant CIDP, or completely an atypical CIDP. If it is an atypical CIDP, then other differentials will come into picture. So this is the importance of the terms GBS and CIDP when we are discussing chronic immune mediated neuropathy. Now coming quickly, we'll go through the various immune mediated disorders. So the Guillain-Barré syndrome, I must emphasize that it is a clinical diagnosis. We do not need a nerve conduction study for us to diagnose GBS or to start plasma exchange or IVIG, especially in a setting when they have respiratory involvement and bulbar involvement. And it is a monophasic illness. And like the neuropathy patterns which we have seen, the presentation is that of a progressive symmetric muscle weakness with hyporeflexia or areflexia, and varied severity of the muscles can be involved. There can be facial, bulbar, respiratory, and limb weakness. And of all the GBS patients, up to 30% will require ventilatory supports. And in the second week of the onset, from the onset of the symptoms, 70% can have dysautonomia, such as severe tachycardia or severe bradycardia up to a asystole, and can have sudden death also if not intensively monitored. Few important points to remember is, if the fever occurs on the day of the weakness, it is not GBS. We need to consider alternative diagnosis such as infective polyradiculitis, such as CMV infection or Lyme's disease or acute HIV seroconversion or lymphomatous infiltration. So that is one important point I wanted to mention. Albuminocytologic dissociation is hallmark of uh, GBS. Having said that, that means the cells have to be less than 5 and the protein should be high. Having said that, up to 50 cells are accepted in GBS group of disorders. But if the total counts of cells are more than 50, then again here we have to carefully look for an alternative diagnosis. We are very familiar with the antecedent infection triggers and the risk factors of GBS. Few important points to remember is that the antecedent infections can occur up to 4 weeks prior to the onset of the weakness. So we need to carefully keep on repetitively asking, was there any event which has triggered? And the usual events which we see are the URIs or the gastroenteritis. And of the bacterial infection, the most common is the Campylobacter jejuni infection, which 30% cases of GBS and 20% of the Miller-Fisher variant can be due to the Campylobacter jejuni infection. Triggers can be the ganglioside administration, recent surgery, recent vaccinations. Now, with immune checkpoint inhibitors, this also is an important to develop GBS. Apart from Campylobacter jejuni, Haemophilus, CMV virus, influenza, mycoplasma, Epstein virus, arbovirus such as dengue, chikungunya in our clinical setting can also cause GBS. Epstein-Barr virus, cytomegalovirus, and Zika virus are known mainly to cause the AIDP variant demyelinating, and the newest one, the group, is the SARS-CoV-2 virus. So, what is the phenotypic spectrum or the clinical classification of the GBS? The GBS spectrum of disorders can be GBS spectrum, or they can have a Miller-Fisher spectrum, or a subset of Miller-Fisher syndrome will have a brainstem involvement that is called as a Bickerstaff brainstem encephalitis. So I'd like to emphasize the point that all these variants come under the umbrella syndrome of GBS. So the classical GBS is the demyelinating axon. So if the axon is just pure motor, that is the Aman variant. If it has a sensory involvement, it has an AMSAN. Pure motor, both upper limbs and lower limb can also some variant called as reversible conduction failure because of the nodes of Ranvier involvement. There can be pure sensory GBS, paraparetic variant of GBS, where only the lower limbs are involved. Facial diplegia and paresthesia, pharyngobrachiocervical variant of GBS, acute bulbar palsy, and GBS with hyperreflexia. And there are various autoantibodies which have been implicated in various variants of GBS, but not necessarily that they have to be demonstrated in CSF or blood. So here, when we are dealing with multifocal involvement sensory motor symptoms, the temporal evolution and whether the symptoms are progressing or not progressing is of utmost importance to figure out, so that it will help us. Anything less than 4, we can be a GBS variant, because that warrants an urgent treatment while we are evaluating for other alternative diagnosis. The other spectrum is the Miller-Fisher. Classical Miller-Fisher we know as areflexia, ataxia, and ophthalmoplegia. So that is the classical thing, is only seen up to 4 to 25% of the GBS cases, and they can present as non-classic forms such as acute ophthalmoplegia, acute ataxic neuropathy, acute ptosis, acute mydriasis, acute vestibular syndrome. So this can cause a lot of diagnostic dilemma in quickly diagnosing whether they are a GBS spectrum of disorder. Hence, we need to be well versed at least with the GBS spectrum, because management makes a lot of a difference in this group of patients. Bickerstaff brainstem encephalitis can be classic here. They can have ophthalmoplegia, as well as once the brainstem is involved, the sensorium will also get involved. So this group of patients will present with acute altered sensorium, ophthalmoplegia, and mainly the brainstem involvement. MRI will be normal. So that will be an important differential diagnosis to keep Bickerstaff brainstem encephalitis. And they can also present with acute ataxic hypersomnolence. And the most common forms are the AIDP, Aman, Amsan variant, and the Miller-Fisher variant. So these are the diagrammatic representation of the various phenotypic spectrum. So the immunopathogenesis of GBS, we'll just discuss about the AIDP and Aman quickly. So whenever there is an autoantigen which is triggered the event, the auto antibodies will bind to the myelin, and then they activate the complement system, and hence a membrane attack complex is formed. Once the membrane attack complex is formed, there is the initiation of the vesicular degeneration. So once the vesicular degeneration occurs, only then the macrophages come and take all the myelin debris and the axon debris. So because of this complement mediated membrane attack complex deposition, the myelin gets destroyed, and hence they cause the AIDP variant of the GPS. Whereas in Aman, the most important structure is the nodes of Ranvier. Now, nodes of Ranvier is further divided into nodes, paranode, juxtaparanode, and internode. And there are various proteins associated. So in the nodes, in the node per se, there are the sodium channel paranodes, there is Casper antigen, other proteins which help in maintaining the myelin sheath. So when there are antibodies against those proteins. So like in the nodes of Ranvier, the main gangliocytes are the GM1 and the GD1A. So when there is antibodies against that, then again the complement membrane attack complex will happen. Then the complement mediated destruction, and again then the myelin will get destroyed, and then the axonal degeneration will start occurring even before the myelin degeneration occurs. So that is the classical way of presenting the acute motor axonal neuropathy. So we know GM1, GD1A, and GQ1B are the most common autoantibodies which are seen. But again, this can be seen only in 30 to up to 20 to 30% of patients. So absence of this does not mean that the patient does not have Miller-Fisher or AIDP or Aman, because I said GBS is always a clinical diagnosis. So there are certain criteria, Brighton's criteria and NINS criteria, which help us to diagnose. I won't go in detail with them, just to know that there are certain criteria for GBS. It is important while we are treating for GBS, or if we have labeled somebody as Guillain-Barré syndrome, we need to look for the red flags. So because of the various different types of GBS variants, they can present as an encephalitis, brainstem, they can present as a brainstem syndrome or anterior horn cell syndrome, or they can have a present like a spinal cord syndrome in an element pattern. So the differential diagnosis to keep in mind is encephalitis, brainstem strokes, especially if there is a Bickerstaff encephalitis presentation. Acute flaccid paralysis, transverse myelitis is a important differential diagnosis to consider. Polyradiculitis, then CMB, CIDP, acute onset CIDP, and neuromuscular junction can also present as an LMN syndrome, such as botulism or Lambert-Eaton myasthenic syndrome. And sometimes functional weakness also can present as an acute flaccid paralysis. So so we need to look out for the red flags in GBS and always keep these differential diagnosis while as and when we are treating for the GBS. The two modalities of treatment for GBS, as we know, is plasma exchange and IV immunoglobulin. There is no difference between the two modalities. For the plasma exchange, we give 4 to 5 plasma volume exchanges, and for IVIG we give 2 grams over 5 days, or 0.4 mg per kg per day for 5 days. And best started within the first 2 weeks of onset of the illness will show the best results. In acute, in GBS, there is no role of oral or IV cortical steroids. Apart from the immunotherapy, we need to monitor these patients for dysautonomia, deep venous thrombosis, DVT prophylaxis needs to be given, and we need to carefully look for DVT formation or pulmonary embolism development. And if they have a respiratory or bulbar weakness, we need to intensively monitor and decide to take over or intubate or ventilate the patient if there is worsening of the respiratory muscle or the bulbar muscle weakness. Once we have given the treatment, sometimes there is worsening of the illness. This can happen in two settings. Either there can be a treatment related fluctuation, which is defined as at least one grade of GBS disability scale or decrease in the MRS score of 1 from the baseline level. Then that is called as the treatment related fluctuation, and is often treated within another course of IVIG or a plasma exchange. The other differential at this time to consider if they have relapsed is an acute onset CIDP, which is seen in a very small proportion of GBS patients, up to 18%. In that case, in addition to IVIG or plasma exchange, steroids can be given. There is a, just for your information, there is a GBS disability scale. Here we follow the modified Hughes score. It helps us to prognosticate at 3 months and 6 months of what will be the level of disability of the patient. Now coming to the CIDP. Now CIDP also is clinically heterogeneous. Grossly, it can be symmetric with sensory motor neuropathies, and it can be monophasic, relapsing remitting, or a progressive. The typical form of CIDP presents as a relapsing remitting disorder, and based on the temporal evolution, the neuropathy progression of symptoms has to be more than 8 weeks for us to label them as a CIDP. And the hallmark problem of this group of disorders are inflammatory mediated demyelination. Hence, immunomodulation is important, and both the cellular and the humoral immunity is affected. So broadly, the CIDP can be divided into typical and atypical CIDP variants. Typical is the sensory motor. This is the usual chronic sensory motor, proximal and distal weakness, or an acute onset CIDP, which is a very small proportion in within the less than 4 weeks we can see. They can also present with a proximal symmetric upper limb and lower limb involvement. And here we need to look out for the other mimics, which we'll discuss in detail. Atypical CIDP variants, the most prominent ones are the asymmetric CIDP, focal CIDP, distal predominant CIDP, that is the distal acquired demyelinating symmetric DADS variant of CIDP. You can have a motor CIDP, and the newest one is a sensory predominant CIDP, is also called as a chronic immune sensory polyradicular neuropathy. So here, both the cellular and the humoral immunity is affected. In CIDP, initially there are active autoreactive T cells. So when there is an antigen which is presented to an activated CD4 cell or an autoreactive T cell via an antigen presenting cells, they cause a lot of they undergo clonal expansion and cause a lot of inflammatory mediator release. This inflammatory mediator breaks down the blood nerve barrier, and this causes the autoantibodies to gain access to the epineurium and attack the specific proteins, and then cause the further complement activation and macrophage related destruction, thus causing the both, either it can cause an axonal degeneration or a demyelinating or a myelin degeneration, and they can present both as an axonal neuropathy or a demyelinating neuropathy. Now, the newer concepts are the nodopathies and the paranodopathies. Just to be familiar with the term, I'm not going in detail with what are the different proteins at the nodes of Ranvier. And just to sensitize that there is a criteria for CIDP, that is the European Federation of the Neurological Society and Peripheral Nerve Society criteria in 2010, which has brought forward a clinical electrophysiological criteria and supportive tests. Apart from it has divided the CIDP into the typical and atypical. The atypical, this criteria recognizes as the DADS variant. MADSAM variant, which is an asymmetric CIDP, stands for multifocal acquired demyelinating sensory motor neuropathy, otherwise called as Lewis-Sumner syndrome, focal, pure motor, and pure sensory. And here we have to rule out that there should not be bowel bladder involvement. There should not be an underlying gammopathy or a mono MGUS or any form of myeloma, and it should not be caused by any underlying infection. I'm not going in detail into the EP criteria. So biopsy-wise, characteristic words which we have heard is an onion bulb formation because of the myelin degeneration. And here, this is the myelin staining, which shows that reduction of the myelinated axons. So treatment, in addition to acute, so treatment is there is an induction and a maintenance phase. Induction is to bring the patient into remission, and maintenance to maintain the immunomodulation so that there is no relapse, no relapses. So apart from the IVIG plasma exchange, corticosteroids is important in CIDP, and they are often used for both for induction as well as for maintenance phase. Apart from IVIG, apart from these treatment modalities for maintenance, apart from corticosteroids, rituximab, cyclophosphamide, mycophenolate, azoran are the other maintenance therapies. Now, coming to the third type of immune mediated neuropathy, which is a multifocal motor neuropathy. Now, this is a pure motor neuropathy, often involves the upper limbs, although lower limbs can be involved rarely, and they are asymmetric presentation. Since the sensory involvement is not there, so we are often mistaken as a element predominant motor neuron disorder with an anterior Hansen involvement. But in reality, in multifocal motor neuropathy, the lesion is at the level of the peripheral nerve, and the immune mechanism is occurring at the level of the nodes of Ranvier, where the GM1 ganglioside is present, and the antibodies against to that cause the destruction of the nodes of Ranvier, and immediately they cause neuropathy and an axonal type of neuropathy. And they classically follow a pattern of multiple mononeuropathy instead of a classical myotomal pattern as seen in ALS. And differential weakness, if the muscles that share a myotome, but they are supplied by the different nerves. And early in the course of the disease, the weakness is out of proportion to the atrophy because there is a conduction failure which is occurring. So the impulses are not going, so they come with an acute, they can come with an weakness very early on the disease. Whereas ALS patients will initially will have cramps, some wasting, and then followed by weakness. Just to also sensitize, there is a criteria for multifocal motor neuropathy also. And exclusion criteria is if there is UMN syndrome, marked bulbar involvement, sensory impairment, which is more than a mild minor vibration loss, and diffuse symmetric weakness during the initial presentation of the development of the symptoms. And usually they present usually they present within 2 to 3 months, and the symptoms should at least least last for more than 1 month, and the motor involvement should be demonstrated in at least two nerves distribution. So the closest differential is, apart from the ALS, is CIDP. So there are various differentiating factors, both clinically and nerve conduction study wise, which help us to differentiate between this disorder. Because why am I emphasizing on multifocal motor neuropathies? Because they are often elsewhere labeled as ALS, not responding, not progressing as an ALS patient. Especially in an element predominant, we need to do 4-point stimulation to look for conduction block. If we are able to develop conduction block, then the treatment of IVIG itself will help in recovery of the muscle weakness and the reversal of the conduction block and improvement. Now, coming to the second half of the talk, which is the neuropathies, which can be associated with the other systemic disorders. So, the predominant disorders are the monoclonal gammopathy of unknown significance, Poem syndrome, IgM gammopathies. Now, IgM gammopathies are various types: primary amyloidosis and paraneoplastic. All of them have immune mechanism and respond to immunomodulation, as well as the treatment of the underlying disorder. And when neuropathies can associated be with other autoimmune disorders like SLE, apart from a CNS, can also have a PNS involvement apart from other organ involvement. So the most important thing, which will be, these five syndromes are the most common syndromes which we see in our clinical medical medicine settings: vasculitis, rheumatoid arthritis, SLE, Sjogren syndrome, and celiac disease. Present, they may all present as neuropathy as their presenting symptoms. So in this, the auto antibodies become very important. So like apart from the GBS and the CIDP antibodies, if the ANCAs come positive, then they are more towards vasculitic neuropathies, rheumatoid factor, ANA, Sjogren's antibodies, SSA, SSB, and anti-gliadin antibodies, TTG. These are all antibodies we can order for when we are considering immune mediated neuropathies. I won't be going into detail for all the systemic disorder. Just that monoclonal gammopathy or unknown significance usually presents like a CIDP presentation, and mostly as a demyelinating type of neuropathy. Why it is important to recognize this disorder? Because the progression to an advanced disease or to a malignancy is 1% per year. So in a patient who has presented with CIDP, we need to look in detail or do extensive evaluation whether to see if there is any paraproteinemic neuropathy. So this MGUS comes under the various paraproteinemic neuropathies. There are three different clinical types which can present as neuropathy. The most common being the IgM class. The second is the non-IgM, and the third one is the light chain MGUS, which can evolve into a multiple myeloma and AL amyloidosis. So, when we are considering paraproteinemic neuropathies, we should always look at the calcium, immunofixation, electrophoresis, serum electrophoresis, urine protein electrophoresis, free light chain, immunoglobulins, and do a basic metastatic bone survey to see if they have some evidence of MGUS, or if they have already progressed into a myeloma or a light chain disorder. Poems syndrome, most of us are aware and would have at least seen one patient during our MD. It stands for polyneuropathy, organomegaly, endocrinopathy, M protein, and skin changes. Here it is again important to know that, because the mandatory criteria is the polyneuropathy and the osteosclerotic myeloma, and the treatment depends on that. And one of the peripheral markers is the increased VGF levels, which is also available in our institution. IgM gammopathy are a group of disorders. There are various types. They also can mainly present with demyelinating type of neuropathy, and it includes DADs with IgM paraprotein, MGUS, Waldenstrom macroglobulinemia. Anti-MAG associated glycoprotein has taken a lot of importance in recent times. Classically presents as a distal demyelinating type of neuropathy. Mixed cryoglobulinemia, Gallop syndrome, which stands for gait ataxia with late onset with polyneuropathy, chronic ataxic neuropathy with diacylosyl antibodies, CanoMad. So in a correct setting, we should be able to make a diagnosis, and neuropathy is a part of this whole systemic disorder. Important thing about DADS, one thing to remember is that the response to plex is not very consistent, because in IgM gammopathies, the IgM protein per se gets replaced every 5 days. So the plasma exchange will not have a long lasting level. So in this setting, IVIG is a better option than the plasma exchange. Waldenstrom's macroglobulinemia also, it's a lymphoplasmacytic tumor, usually present in the seventh decade, and the classical presentation of neuropathy in them is demyelinating with sensory involvement more common than motor, with lower limb involvement frequently seen, and causing more of a sensory paresthesia more than weakness. Mixed cryoglobulinemia, in this clinical setting, they can either present as a sensory polyneuropathy, sensory motor axonal polyneuropathy, mononeuropathy, or a mononeuritis multiplex. We need to understand that initial part of the neuropathy presentation is very important to decipher. So how did the problem start? Did it start as a foot drop or a hand drop, wrist drop? Because by the time the patient presents to you, they might present as a symmetrical polyneuropathy, but we need to discern that how exactly all the forms of weakness started. Then at the presentation, we'll be able to discern that whether it was a mononeuritis multiplex to start off with, now it has become symmetrical polyneuropathy, because eventually all the axonal loss will cause a symmetrical polyneuropathy involving both upper limbs and lower limbs. Gallop syndrome is a rare syndrome which responds to IVIGs and antibody specifically to gallopin. CanoMad is a chronic ataxic neuropathy, ophthalmoplegia, IgM paraprotein, cold agglutinins, and a diacetyl antibodies. They have a characteristic perioral paresthesias in addition to distal limb paresthesias. They can both have demyelinating and axonal pattern. Primary amyloidosis, I want to highlight the fact that they may present only as an autonomic neuropathy, or they can present as simple as like an carpal tunnel syndrome. So in a clinical setting like an edema or a proteinuria or macroglossia, and this will be an important differential diagnosis for an immune mediated neuropathy. Paraneoplastic neuropathies, the classic syndrome is a sensory neuronopathy where there is an involvement of the dorsal root ganglion, seen especially in small cell lung carcinoma. Now with immune checkpoint inhibitors, they can also present as a polyradiculo neuropathy. In a setting of an Hodgkin lymphomas, a very rare presentation of a GBS can occur, and they can present also as a pure autonomic neuropathy with an antibodies against the alpha 3 subunit of the acetylcholine receptor antibodies. Again, we must remember that in a correct clinical setting with the neuropathy involvement, we should be considering this. This per se are very, very rare presentations of the disorders. Now, coming to the last part of the presentation, that is the neuropathies associated with other autoimmune disorders. The most important thing which we'll be discussing is the vasculitis. So, the vasculitis can be systemic or non-systemic. Non-systemic means it is organ specific. The most common form of vasculitic neuropathy which we see is non-systemic vasculitic neuropathy. That means all your ESR, CRP, ANCAs might come as negative. Only on biopsy we might see it as a vasculitic neuropathy. So while dealing with a vasculitic neuropathy, we do an extensive evaluation of the systemic causes, and if all the systemic causes are coming as normal, then we can label them as a non-systemic vasculitic neuropathy and provide immunomodulation. Other systemic disorders who cause vasculitis, the classical vasculitic disorders are the vaginous, PAN, Churg-Strauch's, microscopic polyangiitis, and secondary vasculitis, which can be caused by the rheumatoid arthritis, SLE, or Sjogren's syndrome, hypersensitivity vasculitis, and giant cell arthritis. In our common setting, we see non-systemic vasculitic neuropathy to be the most common, and there are various presentations. They can present initially as a mononeuritis multiplex. then can eventually go into a symmetrical polyneuropathy. That's why, again, emphasizing that the onset of the symptoms of the weakness to elicit is the crux to this diagnosis. So they can also have vasculitic ulcers. Usually they cause axonal neuropathy involving both the motor, sensory, and the local autonomic fibers. So the vasculitic disorder does not see which are the motor fibers or the sensory fibers. And while we are talking about Hansen's, about vasculitis, a very close differential is leprosy neuritis or Hansen's disease. So there are only few conditions where we actually push the patient for nerve biopsy. When we are suspecting Hansen's disease, vasculitis, or when we are suspecting lymphoma. Otherwise, CIDP at NCV EMG in a clinical setting itself, we can diagnose and not require a biopsy. Diabetes, definitely, we do not require a biopsy if we are not suspecting any other underlying monoclonal gammopathy or other disorder. So, carefully in this group of mononeuritis multiplex, I would urge everybody to actually strip the patient and look for any anesthetic or hypoanesthetic patches. Look for, because the sensory involvement in leprosy can be very patchy, anteriorly or posteriorly. We need to do a detailed pain and temperature sensation and touch sensation examination in this group of people. So here in a biopsy, which is showing a very fibrinoid necrosis or transmural inflammatory cell infiltration of a necrotizing vasculitis. This is a case of leprous neuritis. Again, there is a lot of inflammatory cell infiltration, loss of the myelinated, the small myelinated axons, and this is the lepra bacilli. Neuropathy in Sjogren's syndrome classically presents as the non-length dependent neuropathy. That means they typically present with this perioral paresthesia, trigeminal facial numbness, or anterior abdominal wall numbness. In addition to that, they can present as an ataxic sensory neuronopathy because of the dorsal ganglion involvement. So they will be ataxic but with a normal power, and joint position sensation will be absent. Here I want to emphasize that when we are dealing with neuropathy, we just don't check the distal vibration and the joint position sensation. Thus, the fact that the distal joint position sensation is normal does not mean that the proximal joint position sensation will be normal. So, more often than not, in dorsal ganglionopathy, the joint position sensation at shoulder, elbow, ASIS, this hip joint level will be absent, but maybe sometimes present in the distal. Hence, it is very important for a meticulous examination in this group of patient. Apart from the non-length dependent and neuronopathy, they can also present as an autonomic neuropathy, sensory motor, axonal neuropathy, and the cranial nerves which can be involved is optic. The trigeminal neuropathy is very classical in Sjogren's. Facial nerve, glossopharyngeal, vagus nerve can be involved. Neuropathy in SLE, for the peripheral nervous system, they can have a GBS-like presentation, autonomic neuropathy. They can have a myasthenia gravis-like presentation, cranial neuropathy, plexopathy, polyneuropathy. Neurosarcoidosis, again, it is like an infiltrative disorders. They can present as mononeuropathy, mononeuritis multiplex, axonal neuropathy, demyelinating neuropathy, or a very rarely GBS. Neuropathy in rheumatoid arthritis, because of the lot of fibrosis and all, they can present as an entrapment neuropathy, or because of the vasculitis, secondary vasculitis, they can present as a mononeuritis multiplex, distal symmetric sensory neuropathy also, and vasculitis. Neuropathy in celiac disease also, anybody who has a ataxic neuropathy, we need to carefully look for celiac disease, because there is treatment available. So simple treatment available. So here they present as a sensory axonal or a small fiber sensory polyneuropathy, and multifocal motor sensory motor neuropathy can be there, but rare. And other systemic disorders such as diabetes, HIV, Lyme's disease, all they cause more of an axonal or a toxin related or metabolic related neuropathies, but they can also have a immune basis based on different disorders. So, in conclusion, we need to understand that we have to look at neuropathic disorders in a patterned approach. So, please remember those 10 patterns. And it is important to elicit how did the pattern start, at the onset of the disease. The immune mediated neuropathies, GBS, CIDP, we cannot miss. Secondary to the other autoimmune disorders, neuropathy can be a presenting symptom of that disorder, such as SLE, rheumatoid arthritis, vasculitis. Prompt recognition and treatment is extremely important because it prevents disabilities. And always rule out an Hansen's disease in a setting of a multiple mononeuritis or a vasculitic neuropathy. And in a setting of CIDP, always to look out for paraproteinemic neuropathies. Thank you for your patient listening.
Thank you so much, Dr. Deepti. Thank you so much for coming. If there are any questions, you can take questions. There are no questions. We'll end the session. Thank you so much.